అవునా తుయవకంగా
some background noise. Okay, welcome everybody to this webinar on the eve of the World Hepatitis Day. The World Hepatitis Day is coming day after tomorrow, and on this it's usual in AIG to do a program before this. Fortunately for us, we have Dr. P.N. Rao here who's planned out a very nice webinar. This not only concerns with what's happening in terms of hepatitis, but also to acknowledge some of the past leaders in our country who have actually been a part of the development of hepatology. We have a series of question answer sessions which are going to be very short and crisp, followed by acknowledging some of these leaders. Also in this panel we have all the present leaders in hepatology in our country, and we're very fortunate that all of them have agreed to participate. So we'll start this program shortly, and hope you enjoy this program. Dr. P.N. Rao.
Thank you. Thank you very much, Dr. Nageshwari. Well, as you can see here that we are doing it on the eve of the World Hepatitis Day, and you have seen the logo for this particular year, and you can see on the right side, and then that the people cannot wait, the various types of the people who cannot wait for long, and this of course is available on the net, when anybody can go through about it. These are the things, these are the themes, across from 2013 onwards till now, the World Hepatitis Day. And this is Dr. Baruch Blumberg, on the basis of which on the birthday, we are celebrating the day today. And for this, as already been told, we have got a galaxy of speakers. The first session will be Dr. Y.K. Chawla, who is the former professor and head of the Department of Hepatology in PGI Chandigarh, and currently the chair academics, Kalinga Institute of Medical Sciences, Bhubaneswar. And then he would be talking about the stalwarts in hepatology and gastroenterology, Professor Madan Gopalan, Professor Valiyat Balakrishnan, and Professor Sim Habibullah from Hyderabad. And also he would be conducting the session for the speakers here, Dr. Shenoy from Trivandrum, and Dr. V.G. Mohan Prasad from Coimbatore, and Dr. Naresh Bhatt from Bangalore. After these three cases are discussed by the eminent speakers, we have about question time 10 minutes exactly by the watch. And I would request all the audience to post the questions and the comments on the topics which have been covered in this session only. And following this, Dr. Jung Dilawari from UK, he was formerly consultant at GE and senior lecturer at Glasgow University, and he was also the professor and head of the GE and the hepatology in PGI Chandigarh, and he was director of GE department, Max Super Specialty Hospital, Mohali, Punjab. And he would be also be telling about Dr. P.N. Chutani, who was the former director of PGI Chandigarh, and Dr. B.N. Tandon from All India Institute of Medical Sciences, and Dr. D.V. Datta from PGI Chandigarh again. And he would also be leading for the speakers, and he would be moderating the session for the speakers, 4 speakers here, Dr. Kaushal Madan from Delhi, and then Dr. Ajay Duseza is the HOD unit head from PGI Chandigarh, Dr. Vivek Saraswat, professor of gastroenterology from Lucknow, and Dr. Mahesh Goenka from Kolkata from Apollo, and he was the former president-elect Indian Society of Gastroenterology. And again, after the session, there would be a question answer session strictly by the watch by about 10 minutes. And lastly, Dr. Professor Abraham Koshi, who is the director of research in hepatology from Lakeshore Hospital, Kochi, he will be the leading, and he would be talking about Dr. H.D. Desai, Dr. Subhash Nayak, and Dr. Deepak Amrapurkar. And also the speakers in this session would be Dr. Akash Shukla from Mumbai, and Dr. Shalimar from New Delhi, and Dr. Anand Kulkarni from Hyderabad. And lastly, of course, Dr. D.N. Reddy also will be speaking about the endoscopy in people who are HBV and HCV positive. And you can see that we have a galaxy from Chandigarh to Kerala and Mumbai to Kolkata, and this is called the rapid fire, and then case based snippets is there, and the cases will be given to the speakers, and then we'll see how they are going to tackle these questions in a very, very practical way. And then with this short introduction, I would now hand over to Professor Y.K. Chawla, please. Okay, over to you, Dr. Chawla.
Thank you, Dr. PN and Dr. Nageshwar. Can we have the slide? The slide presentation.
Yeah, Dr. Shenoy, please.
Yes. Yeah. I'm just projecting that. Okay. Is it visible now?
Yes.
Yes, it's visible. Can we go to the next slide? I would start talking about Professor Dr. Madan Gopalan, who is all familiar to all of us. He worked in Madras Medical College for a long time. He contributed significantly to the development of Budd-Chiari syndrome, and let's, in his honor, have the first case. Next, Dr. Shenoy. Yes, so this patient that we are discussing is a 26 years old male who is an IT professional having a BMI of 24. In 2005, incidentally, he was tested positive for HBsAg. When he was undergoing pre-anesthetic checkup for surgery for anal fissure. He was asymptomatic, did not take liquor, had no family history, no past history of having suffered from any acute hepatitis-like illness, no previous surgeries, blood transfusion, dental procedures, exposure, and his clinical examination was unremarkable. He was E antigen negative, anti-HBe positive, HCV and HIV negative. Ultrasound showed a grade 2 fatty liver and no splenomegaly. Hemoglobin was 12.5 with platelets which were normal, and his viral load that was done showed 9,405 copies. His bilirubin was 0.8 to 1.1. SGOT, SGPT was marginally raised. SGOT was 42 and 52 at 2 intervals. In 2007, SGPT 40 and 40, alkaline phosphatase was normal and albumin was normal. So can we have the discussion from Dr. K.T. Shenoy?
Thank you, Professor Chawla, Dr. Nagi, and Dr. P.N. Rao. This case, which was given to me by Dr. P.N. Rao, is something which we see every day in our clinical practice. Summarizing, a young male with elevated ALT of 76, a DNA with 9,405 copies or 1616 IU per ml, a fatty liver of grade 2 with a normal platelets and a E antigen negative. What we have to do in the therapy decisions is to assess this young man as to what is the type of hepatitis he has, chronic hepatitis. And the question which comes to me is, should I treat him or why not treat him? And the evidence for treating and the final decision whether to treat and or not to treat. The treatment indications depend upon the different phases of HBV. This is a recent update on HBV treatment based on the type of infection, the E positive and E negative. We will focus on the E negative. So this gentleman has got a E negative chronic infection. The old terminology is an active carrier. We don't know the viral load as per the HBsAg status, but I believe it will be a low HBsAg. His E antigen is negative. His DNA is definitely less than 2000 IU per ml. His ALT is not abnormal. This is something which is not in favor of the chronic infection. So it is between chronic infection and chronic hepatitis. His liver disease, for all practical purposes, cannot be none. It will be mild to moderate, and we do not know about the disease progression. And the treatment, as per this indication, it is not indicated. But I don't believe that we can put this patient in a E negative chronic infection. I will come to this a little later. So we have to evaluate this young man with a pre-treatment. We know that he has got an ALT which is more than 70, which is 2 times upper limit of normal. There are some Indian standards which have been laid down, but I believe that anything above 35 IU is definitely abnormal. His E antigen is negative and anti-HBe is positive. We don't have the genotype, but we know for definitely that he has got a fatty liver of grade 2. We don't have any elastography with this gentleman. He has no alcohol abuse and the MCV is normal and the platelet counts are normal, which indicates that he has no evidence of portal hypertension. Now, some of the non-invasive tests which can be done in this young man to say that he has no fibrosis will be a fibroscan, a transient elastography, in the absence of which I believe that he will be most likely in the F1 grade, which is less than 7.2 as per the Indian standards from Calcutta. Now, why we should treat him? Though the evidence is not for treating him, I believe that the REVEAL study is the most important parameter which we have to take into clinical practice. This is a long-term study, and you can find that when the copies of the virus is between 300 to 9,999, and our case will be fitting into this. You see that there is a risk of HCC 1.37 times compared to the normal at about 15 or 16 years of follow-up. Cirrhosis after 11 years of follow-up, it is 5.9 times compared to those with a DNA of less than 300. So I believe that this patient, if I don't treat, is likely to progress into cirrhosis over a 13-year period to the extent of 6 folds to the normal, which means he requires treatment as per the REVEAL data. Though the classification of hepatitis B, which has been the recent one, the chronic hepatitis, E positive and E negative, infection versus hepatitis, I believe that this patient will require treatment based on 3 important factors. He has a little more viral load. He has an ALT which is more than 2 times upper limit of normal. Though his age is young, I beg to disagree with the guidelines because guidelines will come only after 6 or 7 years. But based on the REVEAL study, I will treat him, and the decision to treat will be based on a few things. I should counsel him on the need to treat, how long he should take the treatment, at least for 5 years. His family members have to be screened. So screen and then decide to treat them. We have to reassess every 6 months with HBV DNA and a quantitative HbSAg and an imaging technique. What is the treatment? I'm not going to elaborate on the treatment except to say that I will be treating him with tenofovir alphanamide 25 milligrams daily, reassess him every 6 months for the viral DNA, the quantitative HbSAg, which will be a good indicator to say that this person has responded to treatment. And we will be reviewing him maybe at the end of 3 or 4 years. I don't think I will take a liver biopsy in this patient, but I may do a fibroscan probably at the end of 1 year, and I may also do in the basal stage and follow him for the next 5 to 10 years. Thank you very much.
Thank you, Dr. Shenoy, for your presentation. We'll have questions in the end, but I want to leave you with 2 things to ponder during the questions.
Yeah.
Since the WHO wants elimination of hepatitis B by 2030, you said you would treat this patient, but that also should be a parameter. And second, this patient had fatty liver, which also could be contributing to raised enzymes. So we can have the answers later. So we move on to the second case. Can I have the slides,
Dr. Mohan Prasad.
VG? Now this case snippet is a tribute to Professor Balakrishnan, who again has been our teacher, and we all know him so well. Unfortunately, he left us some time back, but his pioneering work on chronic pancreatitis would always be remembered for generations to come. So we present the second case now, and I request, can we have the second slide? Yes. This patient, VG, this patient, Mrs. JK, 35 years, housewife, BMI of 26, beyond the upper limit, was detected to be positive for surface antigen during routine antenatal checkup at 10 weeks. And on investigations, she had a bilirubin of 3.5, mainly unconjugated, AST 42, ALT 46 with an upper limit of 40, ALPHOS was normal, albumin was normal, INR 1.3, and creatinine was normal. And on hemogram, her hemoglobin was 12.5 with normal platelets. She was surface antigen positive, E antigen negative, anti-HBe positive, HCV and retroviruses, they were all negative. Ultrasound abdomen showed a liver which was normal, no splenomegaly, no ascites. And she had a live fetus. So she is a 10-weeker who has been found to be surface antigen positive. Over to Dr. Vici.
Thank you so much, Professor Chawla, and to my greetings to Professor P.N. Rao and Nagi and the team. My salutations to all the gurus who are going to follow me. So I have in front of me a 30-year-old female in the first trimester of pregnancy and incidentally detected to have hepatitis B surface antigen positive status. So what are the problems that I'm facing? One is hyperbilirubinemia, which is more of indirect hyperbilirubinemia, unconjugated fraction. Upper limit of normal of transaminases, no cirrhosis, HBsAg positive, E antigen negative, anti-HBe antibody positive, indicating this is just not a simple carrier state. So this is a seroconversion of the envelope antigen status. So probably I would think this is smoldering chronic E negative hepatitis as we see in this country. What I used to see 30 years ago was only 25% were mutants. Today, 90% are mutants in India. So it could be chronic E negative smoldering hepatitis going on in this lady. So I need these tests. HPV DNA quantitative PCR we don't have. And genotype may or may not be important because majority of genotypes that we see in South India is genotype G. We ourselves have published data on that. And genotype A is seen in Trivandrum or Mumbai or Delhi, but not much of C. People have shown that genotype C can produce problems in pregnancy. And then I would do a shear wave elastography. Here again, the normal shear wave values have been worked out, the FibroScan values in pregnancy. So the first trimester has a borderline higher than normal, up to 4.5 kilopascals. In second trimester, it goes to 6. And in third trimester, it goes to 7. But anything above 7 is abnormal. If it is 7.5 fibrosis, even they can get a chance of developing preeclamptic toxemia. So, so the moral of the story is shear wave elastography does help in pregnancy to assess how much of fibrosis. If somebody has F2, F3 fibrosis, I'll be a little concerned. Then, of course, I would do a gamma glutamate transferase. Alkaline phosphatase is no use because it could be placental. And then I would do vitamin B12 deficiency state, I would rule out because I see in my place in Coimbatore, a lot of people with indirect hyperbilirubinemia is just because of hypovitaminosis B12. Then I can go ahead and treat it and check what happens to the bilirubin levels. Because that is the only thing which is little above the enzyme level, right? So the questions to be addressed: one, does she need to be initiated on antivirals? And if so, are we treating the mother to prevent a flare, or are we treating a mother-to-child transmission? So what is the impact of chronic asymptomatic hepatitis B on maternal health? Is there a chance of hepatitis flare or decompensation is an important slide. And you just look at this, the flare or decompensation can happen in immediately following pregnancy because pregnancy itself is an immune tolerant phase associated with high levels of adrenal corticosteroids. In a prospective study with 126 pregnant women, during pregnancy 2, whereas 27 had flare during postpartum period. Because the postpartum period is an immune reconstitution phase, which is analogous to the corticosteroid withdrawal in chronic hepatitis B. So decompensation could occur during the flare. Flares are more common in E positive mothers. In this case, the chance of her developing flare is only 2% because during pregnancy we are spotted. Number two, she is E negative. So the chances of flare is slightly lesser. So that is one thing that we have to remember. So we are not really bothered about flare and the treatment of mother in this situation. And how about the impact of mother to child transmission? You see, 50% of the global hepatitis B burden today is because of MTCT. 90% of MTCT occurs in the peripartum period, not earlier. So, and less than 1% postpartum. So we are in the first trimester, so not in the third trimester. But however, impact on immunoprophylaxis and chemoprophylaxis and MTCT has been shown in beautiful studies. So with no infant HB-IgG or vaccination at birth within 12 hours, and no maternal chemoprophylaxis in third trimester, risk of CHP in child is 90%. With HB-IgG and vaccination in the newborn and no maternal chemoprophylaxis, still it's 9%. Risk of transmission, especially so in E antigen positive mothers. With HB-IgG and vaccination and maternal chemoprophylaxis, the risk of chronic hepatitis B is only 1.54%. So especially so in even if this HBe antigen positive and high viral load. So going to the algorithm, simple algorithm follow. So first pregnancy visit, HBsAg and anti-HBs has to be checked. So forget about this group. This is HBsAg positive as you see in this mother. Now we'll have to look at DNA now and at 28 weeks. So what is the ALT level? Whether E antigen is negative. Here ALT normal, E antigen negative, and anti-HB is already seroconverted positive. Then we look at the DNA. If the DNA is more than 200,000 international units per ml, consider treatment at 28 weeks to 32 weeks, not in the first trimester. If it is less than 200,000, no antiviral therapy is required. This is what the whole story is about. So, and the infant, of course, receives vaccine and HB-IgG at birth. So, and if at all we are using an antiviral, because we don't know about the viral load in this patient and we don't know the fibrosis score of this patient. So, assuming we need to start tenofovir, is it safe in first trimester pregnancy? Is the question that I want to address. You see here, the prevalence of congenital anomalies. This is the antiretroviral pregnancy registry. The prevalence of congenital anomalies in the first trimester, if used exposed to TDF in first trimester, is only 2.3%. And even in second or third trimester, it's only 2.4%. Here again, this is lower than the non-TDF exposed mothers, which means TDF, that is a tenofovir, it is better to start at 28 weeks. Even then, if you have to start even during first trimester, still it's safe. And so when to initiate therapy, this is my last slide. If active disease or cirrhosis is present, we need to start even in the first trimester with tenofovir or telbudine. Tenofovir is probably the commonest that we use because HPV-related cirrhosis patients have a high incidence of flares during pregnancy. And ultrasound says no cirrhosis. I will not believe because I have demonstrated in studies that until the fibroscan values go up to 20 kilopascals, the ultrasound still does not even say there is worsening of ecotexture, which means from anywhere between 12 kilopascals and 20 kilopascals, that gray zone, we will really miss out. Just based on ultrasound, if you decide there is no cirrhosis, that you might be wrong. So if there is cirrhosis, we need to treat in the first trimester because that could be a flare, 15% chance. And to be continued on antivirals before pregnancy, if somebody is continuing on antivirals before pregnancy, please continue it because otherwise flares can happen. And when to differ? If the viral load is more than 2 into 10 to the power 5 international units, we have to initiate in the third trimester, even if ALT is normal. And you can defer therapy until delivery if there is only a mild disease act. I think that is my last slide. I should thank you for this opportunity and the patience.
Thank you, VG. What I gathered was that you would observe this patient till you have a DNA report in the third trimester and then plan for an antiviral. But just 2 points at the time of discussion. Is doing FibroScan safe in pregnancy? Number one. And number two, the patient had unconjugated hypobilirubinemia. Apart from B12 deficiency, can you think of something else? We move on to the third case. Things to ponder at the time of question answers. Yes, we have Dr. Naresh Bhatt with us, and this presentation is in honor of our dear Professor C.M. Habibullah, who again has been a well-known figure. He's been a master in stem cell therapy, and he pioneered a lot of work of the role of stem cells in acute liver failure. So let's have the presentation in his honor by Dr. Naresh Bhatt. A 50-year-old male in June 2008 had history of tiredness, progressive distension of abdomen with swelling of both feet of 3 weeks duration. He was well prior to this, no comorbidities and not on any medication. He was a teetotaler. On examination, he was well preserved, icteric, pedal edema was there, no flaps, and on abdominal examination, he had splenomegaly and ascites, but liver was not palpable. So the clinical impression was decompensated chronic liver disease. His hemoglobin was 11.8 and platelets 63,000. Bilirubin was 3.1, conjugated 1.5. Albumin was on the lower side, 2.3. AST, ALT was 501 and 352 with alk-phos of 279. His INR was 1.31, MELD of 15, creatinine 1.1, alpha-fetoprotein of 12.1, and he was surface antigen negative, but anti-HCV positive genotype 3 with a high viral load. Ascitic tap showed an ascitic protein of 1.2 with SAG of 1.4. Ultrasound was classical of a shrunken liver with no focal lesion. And on Doppler, they found a thrombosed portal vein. And on endoscopy, he had grade 2 esophageal varices with mild portal hypertensive gastropathy. So over to Dr. Naresh Bhatt.
Thank you, Yogesh, and thank you, Dr. P.N. Rao, my teacher, for having me here this evening. So what is obvious in this patient? Dr. Koshi taught us that a patient who has got splenomegaly and ascites definitely has portal hypertension, and we have correlated this with the presence of esophageal varices. We have clear evidence of a decompensated liver disease. He has no encephalopathy and no organ failure. I'd have liked to have more information on his nutrition and the presence of comorbid illnesses. So what are the issues? What has happened to this patient? He obviously has had an acute injury with recent worsening. Now, to my mind, what are the possibilities? Either he's had a new infection in the liver per se. He could be having a spontaneous bacterial peritonitis, a portal vein thrombosis, Budd-Chiari, an HCC, or whether he has a drug-induced liver injury or even with complementary alternative medication. We have high enzymes and a portal vein thrombosis, and we do know that while high enzymes can be because of many causes, including an infection, portal vein thrombosis, an acute portal vein thrombosis can also cause microvascular thrombi in the liver and cause some amount of ischemia of the hepatocytes. What is important to note that this gentleman has got a genotype 3A, which has relevance from his management point of view. But the issues are, can it still be a superimposed infection? Have we ruled out any infections? Have we conclusively excluded a drug-induced liver injury? I think we need to have more history gathering to elucidate these facts. The ultrasound notwithstanding, is it still possible that he has a small HCC which can get picked up with better imaging? What do we do about the portal vein thrombosis? And is it safe to treat this patient Hep C with high enzymes and who has decompensated? So the investigations that I would want is to look for other infections like hepatitis A and hepatitis E. So I would get specific IgM antibodies. I'd also look for other viruses like hepatitis B, and I'd get an anti-HB and HBV DNA, because you can have dual infections and you can of course have an HIV to complicate the picture. So I think these are important data that one must gather before we plan therapy. And of course, the most important thing would be to get a triple phase contrast and a CT scan to look for the liver, especially to pick up an HCC, and also throw more light on the nature on the portal vein thrombus, whether it's tumoral or non-tumoral. As far as the management is concerned, nutrition certainly, all of us know about the proteins, a low salt and the nighttime snack, which is important to prevent hypoglycemia in these patients. I will not dwell further into it. Beta blockers would be essential. Few years ago, there was a sentinel study which came out and said that there's a window hypothesis, and that if you go beyond that window of usage of beta blockers, it will do more harm than good. But subsequently, there's enough data to suggest that this is not entirely true.
No, any
But we
questions?
need to pull out the beta blockers or avoid only if there's hypertension or decreased organ perfusion, SBP, or a truly refractory ascites. So this gentleman, I would consider beta blockers. Diuretics, of course, with his ascites and edema, we have little choice but to use diuretics. Now the question is the portal vein thrombosis, and we are aware that one of the most important factors is the presence of an HCC, which can actually give a tumor thrombosis, or other factors affecting the flow in the portal vein, which can predispose to a thrombus, or other thrombophilic conditions which can coexist in these patients and which may have relevance as far as management strategy is concerned. So is there a role for anticoagulation? Yes, it was controversial some time ago. People were scared of using anticoagulants because they were worried about the bleeding complications in cirrhosis. But we do know that this is no longer an issue. This patient has had a fairly sudden decompensation. No other factor is sort of evident right now. So I would assume that possibly this is the factor, but then as I said, we need to look at other investigations that I have alluded to earlier. In our unit, we prefer to anticoagulate these patients for at least 6 months, and we generally use low molecular weight heparin followed by oral anticoagulants. In this patient, there has been a delay of 3 weeks. And he has got child B, male 15. So these are patients who perhaps don't resolve their thrombus so well, but yet I would give him the benefit of low molecular weight heparin. Of course, if you have pain or an SMV involvement or splenic vein involvement, then the justification for anticoagulants is stronger. Of course, if he doesn't have an HCC, obviously, but if he has HCC, then you'd perhaps consider whether it's worthwhile giving it or not, because these patients don't do too well. So if you look at this meta-analysis that came out very recently, we know that the response is less in advanced disease and HCC. The risk of bleeding in these patients is not so significant. So I think we should give it for whatever benefit we can get of recanalization and survival. The choice of anticoagulants is not clear, but I think the evidence suggests that low molecular weight heparin would be preferred. And there's some evidence that direct oral acting anticoagulants may be the way to go, though the data is still quite limited. Duration is at least 3 to 6 months and longer if he's a liver transplant candidate or if there's an SMV involvement. However, there are no RCTs that were considered in this meta-analysis, and therefore the quality of evidence is thought to be poor. This is kind of an algorithm that came out last year, which some people may find it interesting. So I'll just leave it at this. That is important to know whether there's a thrombophilic state, and that will decide the duration of therapy. Finally, what is the treatment for hepatitis C? We do need treatment. There's no doubt about it. What are the factors that I would consider important to decide? Is that this patient is cirrhotic and he has decompensated. The good thing is that his renal function is good. His platelet counts are around 60 and not too bad, not 30,000 and 15,000. And he is treatment naive. So what is obvious is that we're going to use a non-interferon based regime. And the regime that has come out with the best kind of results are a combination of sofosbuvir, veltazpir, and ribavirin for 12 weeks with an 85% kind of response. Only dual therapy for 12 or 24 weeks in this trial did show great sort of response, only about 50%. So it is imperative that we do consider ribavirin as part of the therapy in these patients. Obviously, you would monitor them closely and look for sustained viral response after stopping therapy after 12 weeks. I'll stop here and maybe we could discuss other issues if they do come up.
Thank you, Naresh. What we have gathered is you would like to treat this patient for hepatitis C, at the same time put him on anticoagulation for his portal vein thrombosis. Certainly, liver transplantation has to be kept in the back of mind if the patient doesn't respond. So with these three presentations, let's go to the question-answer session.
Thank you, Dr. Yogesh, and other speakers, Dr. Shenoy, Dr. Mohan Prasad, and Dr. Naresh Bhatt. We have some questions, mainly pertaining to, everybody is asking only one question. There are 4 questions are there, which they said NAFLD, metabolic syndrome, and hepatitis B is also there. What do you do about them? But this question specifically, I have requested Dr. Ajay D'Souza from PGI Chandigarh to take up this question, and then he would be elaborating on how to go about when HbS-CAG is positive and a metabolic syndrome is also there, and what is the influence of obesity and metabolic syndrome on a course of the HbS-CAG he is going to take up. For Dr. Mohan Prasad, there is one question is there, that is 7th month pregnant and 20,000 international units. No other data is given here. As you can see in your case here, it was an unconjugated bilirubin, has already been pointed out that must be a Gilbert's pre-existing. Albumin is commensurate with the pregnancy. Slight elevation of ALT, AST was there, So 20,000 units, what will you do in 7th month? You are muted, Mohan. Mohan, you are muted.
Okay. Actual recommendation is when there is a high viral load of more than 200,000, then only, the chance of MTCT has been pointed to be high. But I do treat even if there is 20,000. I don't follow the guideline. I do treat because I need to protect MTCT, because one of the major problems in India. So we need to protect these children. So as I demonstrated in several studies, the conjugated view is that, it definitely breaks the transmission. So I would treat.
Yeah, this is what Dr. Shenoy also told about it. There's a beyond the guidelines, sometimes guidelines take care of only few things. But in a real practice, it is going to be different, and then you have to devise in your own way what are the risk factors associated, and then you have to take care of it. What Dr. Shenoy's case, which I have given, is a cross. That means viral load is low. According to viral load, you should not be treating, at least by the EASL guidelines, which are standard for 2000, irrespective of whether it's a E positive or E negative, and the enzymes are slightly higher there. So that's where he said that he would like to treat.
Sir, can I also pitch in here?
Yeah, please go ahead.
Why? One is Gilbert syndrome can happen because of this UGP1A1 deficiency, which can happen in cirrhotics. So if this is an acquired Gilbert, and Professor Chawla was pointing to that. And like it's not a congenital, or inherited Gilbert, then I would think probably she has more fibrosis. So I would like to see her result of the fibroscan. And then this is obviously a non-hemolytic type of jaundice, because the peripheral smear you pointed out was normal. Hemoglobin 12.5 is normal in pregnancy. So I would think that there is no hemolysis happening. There's not a hemolytic indirect hyperbilirubinemia or unconjugated that we are seeing. Probably it's an acquired Gilbert.
Okay.
That's what I would think.
And also the last case by Naresh Bhatt is clearly an example where there is a sudden elevation of ALT and then AST in a patient who is been comfortable so far, and you find that there is a thrombus. It is a harbinger of a malignancy. First thing is, of course, as I already told, that he wants to have a more imaging to see whether the thrombus is a bland thrombus or whether it is a tumor thrombus. Once the tumor thrombus, the entire scenario is different. If it is a bland thrombus, again, you have to do, as you said, that we should not be shy of doing anticoagulation in these patients. Many people think that thrombocytes are low, INR is this much, so you should not be doing. But anticoagulants have to be given, especially if a patient is being considered, because that is the start of a decompensation in these patients is a portal vein thrombosis. Over to Dr. Chawla for your comments. Then we can wind up and then go for the next session.
I think things have been adequately discussed. In the first case, enzymes rise could be because of associated NAFLD, fatty liver was there. And I agree with Dr. V.G. Mohan. There's a lot of hue and cry for elimination of hepatitis B. We have to modify our guidelines. If you're not treating tolerant individuals, patients with lower HBV count, when are you going to achieve hepatitis B elimination? It's going to be 2050 or 2060. So that has to be kept in mind, but these guidelines have to be altered. I don't think I have anything more to say. It has been adequately and very well discussed by all the three speakers, and very grateful to P.N. Rao and Dr. Reddy. Thank you, P.N.
Thank you very much, Dr. Chawla. And then with this, we'll go over to the second session, which will be steered by Dr. Jang Dilavari from UK. I would request Dr. Kaushal Madan to start sharing his slide, and then over to Dr. Jang, please.
Hello, can you hear me?
Yes.
Well, the first case is dedicated to the memory of Dr. P.N. Chitani. He died at the age of 81 in 1996. Dr. Chitani's photo is not there.
Okay, it will come in the next one anyhow. In the next session it will come. You can continue to talk about Chitani.
Okay.
And then, because there's a reason why I put all the three slides, right? Okay. Keep going.
Well,
sir.
I think we should see Dr. Chitani's slide, no? Anyway, doesn't matter.
Unfortunately, I did not receive that particular slide in which
Okay.
photographs.
Dr. Chitani was a phenomenal man with razor sharp intellect, and he was always punctual in meetings 5 minutes before. He took particular interest in keeping PGI very clean. He used to pick up cigarette stumps from walking on the corridor of the PGI, and in public toilets, he will go himself to the male toilet to see if they are clean, and send his female resident to make sure that the female toilets are clean, public toilets. And if they're not clean, he will pull up the medical superintendent and say how dirty they are. Please do something about it. Chitani was one of the founder of the PGI, Chandigarh. He developed the Department of Gastroenterology. It was the first, was created in India 60 years ago, the super specialty of gastroenterology. He was very patriotic, Gandhian, and vegetarian at a very early age of 23, and remained bachelor throughout his life, although he did like the companies of the ladies because he was a great charmer. He was dedicated to the medical education and to the development of gastroenterology in India. He has a large number of awards, particularly Padma Bhushan, and he was among the physicians who received the Peace Nobel Prize in 1985 for prevention of nuclear war. And at the end, he donated most of his wealth to PGI, Punjab University, and Health Center in Chandigarh. Now over to Dr. Kaushal, Dr.
Dr.
Kaushal Madan's case.
Dr. Kaushal will be discussing about this case. Can you take over the next slide, please, Dr. Kaushal? And briefly, this is about the 45 years female who has come with hepatocellular jaundice of a 1 month duration, and she had hepatomegaly of 4 centimeters, and the spleen was palpable. And if you go to the next, on the right hand side panel, you will see that if you see the LFT, the SGOT is more than the SGPT. In this particular scenario, her platelet counts were normal, 1.6, and she was positive for HBsAg, and also because being a female, at that point of time, SGOT is more than the PT, which normally is what happens reverse of any hepatitis, where there is a SGPT is more than the OT, and then we have done ANA, which is positive in 1 in 100 titer, and there were no varices, USG, there is no evidence of any chronic liver disease. Portal vein was 9, and then spleen was slightly elevated. How would you go about, Dr. Kaushal, in this patient who was HBsAg positive and also ANA is positive? Over to you, Kaushal.
Thank you, sir. Thanks to Dr. Rao and Dr. Reddy for involving me in this particular session. Now, going with the theme of the session, that is a rapid fire round, so I'll try and present it very crisply. So like Dr. P.N. Rao just presented the case, so we have a patient who has acute hepatitis-like picture, AST more than ALT, slightly raised globulin, positive HBsAg, all other viral markers negative, and ANA was positive 1:100 and mildly positive ALKM1 and negative ASMA. So to summarize, we have a middle-aged female. This is very important. When we are talking about patients who present with acute hepatitis B-like picture, their age is very important to determine whether these patients might be having chronic hepatitis B underlying with reactivation, or it is acute, or it is something else, or they may only be a carrier. Second, the presentation is acute hepatitis B. Why? Because the enzymes are very high. So always remember, when the liver enzymes are more than 10 to 20 times upper limit of normal, there are only 3 or 4 differential diagnoses. One is acute viral hepatitis, second is drug-induced liver injury, third is ischemic hepatitis, and fourth is autoimmune hepatitis. So when you have such high enzymes, this is acute hepatitis. Now, along with that, HBsAg is positive as per the information, and ANA is positive. So with this, the differential diagnoses are these. It could be acute hepatitis B. It could be reactivation of chronic hepatitis B. It could be acute hepatitis E over an HBV carrier state. Remember, the most common cause of acute viral hepatitis in India is acute hepatitis E. So with a prevalence rate of hepatitis B of 1 to 2%, there is no stopping that a HBV positive patient who's just a carrier can develop a superadded acute E. Similarly, this could be acute hepatitis A over an HBV carrier state, or it could be a drug-induced liver injury over HBV carrier state, or an AIH flare over an HBV carrier state. So these three are eliminated. IgM-HEV, IgM-HAV were negative. The history, very well presented by Dr. Rao, suggested that there was no exposure to any hepatotoxic agent. So we are left with these 3 differential diagnoses. And in our clinical practice, the most difficult one is to differentiate between acute hepatitis B and reactivation of chronic hepatitis B. So these are the labs or the further investigation which would help you make a diagnosis. An IgM antibody to core antigen, hepatitis B E antigen, HBV DNA load. Remember, this has to be done in all cases of patients who present with a positive HBsAg report. I have seen many physicians not ordering HBV DNA because of the risk of the cost, involved. But remember, you will not be able to do justice to the case if you do not order an HBV DNA load. Apart from that, since ANA was positive and her immunoglobulins were elevated, you would want an IgG level, which will help you support the diagnosis of autoimmune hepatitis. And ASM and ALKM1 reports were already given. So what will happen? What would happen to these markers if patient has acute hepatitis B? The IgM anti-HBC would almost always be positive in a patient who has a HBV acute. And if you go deep, there will be a history of recent exposure or percutaneous exposure in last 3 to 6 months. Just to give you an example, I recently had a young boy who presented with acute hepatitis B, and I was not sure what I was dealing with. When one of the parents asked me, "Sir, isn't sexual exposure a known risk factor for HBV?" I, from my side, was also surprised. I didn't want to ask such a history from the parents. The parents gave me this history that yes, the boy had been exposed to this. So if you go a little deep in the history, you'll get the history of percutaneous exposure, like a dental treatment or a blood transfusion or a recent surgery where the patient might have been exposed to blood or blood products. The E antigen usually will be positive. The DNA load, this is very important. If you do the DNA load immediately when the patient has acute hepatitis, it will be high. In order to differentiate, the DNA load done at around 3 to 4 weeks after onset in acute hepatitis B would be low or receding. That is because the immune system of the body is rapidly clearing the infected hepatocytes and the virus is dying along with the hepatocytes. So DNA load will be low. The positive ANA in such a case may just be an epiphenomenon. Always remember that this may just be a red flag, and Dr. P.N. Rao knows it. That is why he has put that in the equation. Second, reactivation of chronic hepatitis B. Remember, IgM anti-HBC, we think it is negative, but it may be positive in a large number of cases. However, the titers of anti-HBC, if they are available, would be low. E antigen may be negative or positive because during reactivation, even the E antigen may become positive. However, there was a study from Dr. Sareen's group which suggested that if E antigen is positive, along with that, if anti-HBE is also positive, that may suggest a reactivation of chronic hepatitis B. And again, as I told you earlier, if DNA is done around 3 to 4 weeks, and if it is high, more than 10 to the power 5 international units per ml or more than 5 logs, then it is most likely a reactivation of CHB. And again, positive ANA may just be an epiphenomena or a red herring. So when in doubt, what happens if you are not able to make sure whether the patient has acute hepatitis B or chronic hepatitis B with reactivation? The only issue is whether you start them on antivirals or not, because AVH would resolve on its own in 99%, whereas reactivation would always require antiviral. So when in doubt, don't go into academics, just treat with antivirals, nucleoside analogs. Remember, they are very safe. Even if you have erroneously treated acute hepatitis B, all you will achieve is a negative HbSAg after 6 months. So you've achieved what you would have wanted to achieve. So don't hold back. If you have doubt, you can be confident, fine. If you have doubt, treat with antivirals. And finally, what happens in an AIH flare? The IgM anti-HBC would be negative, E antigen would be negative, DNA load would be very low to negative. Remember, we are saying that this is an AIH flare in a carrier. So all these things, the B markers would be the way I have written here. The positive ANA and ASMA may suggest AIH. The IgG, which would support the diagnosis, would be elevated to more than 1.1 times upper limit of normal. And always remember, don't start steroids just on basis of a positive ANA. Always get a liver biopsy to confirm whether this really is autoimmune hepatitis or not. That would be all for now. Thank you.
Kaushal, in your case, the IgG immunoglobulins are normal. And ANA, you're saying, is epiphenomena. So it is not an autoimmune hepatitis.
I agree, sir. I was just discussing the differential diagnosis. I would IgG levels were not shown in the was not given in the picture.
Right.
We did not give an IgG, but ANA titer is more than 1 in 100, and then that is significant. Of course, we'll go on to the next, and then we'll discuss.
Why is it splenomegaly? How
Just
do you
before we
explain
move on, the titer of ANA is never used to make a diagnosis of autism.
Yeah. And this patient had a splenomegaly. Is it because of the acute hepatitis or reactivation? What is it?
Yes, sir. I think it would be because of acute hepatitis of any cause may have splenomegaly in about 25% of patients.
Okay. We very well discussed this case. And I think we can go to the next case.
Yeah.
Ian?
Dr. Ajay Duseja, please, can you come on to the...
The next case, thank you for having these pictures now, at last. We already talked about Dr. Chitani.
Yes.
And this second case dedicated to the memory of Dr. B.N. Tandon, who died at the age of 87 in 2018. And he actually the main builder of the Department of Gastroenterology in All India American Institute, which is started in 1973. He is a very dynamic person. He actually also established the Department of Surgical Gastroenterology, providing the MCH degree course first time in India. And this shows how dynamic he was. His main work, for which he is remembered in hepatology, is on subacute hepatic failure, which is similar to ACLF. And he received lots of awards. He was president of the ISG, and he was president of the International Association Study of Liver, and also a PASL. And he received Padma Bhushan Award in 1986. Now let's discuss now the case of Dr. Ajay D'Souza. Ajay D'Souza, you got to this case. Can we have this slide, please?
Just a minute, sir. Just a minute. There's some problem with my slides here.
Well,
Can you?
I have this slide with me.
No. Can you see my slides, sir?
Oh, yes.
No,
Yes.
I know
Can you see the slides, sir?
Yeah.
No, I don't have this slide, but I have
Can you see my slides, sir?
Yeah.
No.
I can say move on. Move the next one, please.
Yes. Can you see this?
I can see now.
Yeah, we can see that. We can see.
So
Okay.
this is a 45 years old male whose BMI is 29.5. He's known diabetic for 14 years, but poorly controlled. Age of 32, that is mean 13 years ago, he was directed to be hepatitis B surface antigen positive, and during pre-anesthetic checkup for elective cholecystectomy, his liver was found to be fatty. At laparoscopy, an ultrasound showed fatty liver and gallstones. Liver function tests were normal except SGPT is slightly raised, HBDNA raised 2600, and he was started on entecavir, and which he has been taking regularly without fail till now, and the HBV DNA detected throughout, and his AST, ALT, however, remained mildly elevated at 45 to 76. Now, on routine clinical checkup, he was found to be having mild ascites, grade 2 esophageal varices, and FibroScan liver stiffness measurement was 14.5 kilopascal, and controlled attenuation parameter of 359, which indicates a fatty liver. His question to you, Ajay, is why did I develop cirrhosis of the liver, although I've been taking entecavir without fail for the last 13 years? Ajay.
Thank you, sir. And at the outset, my sincere thanks to Dr. P.N. Rao, Dr. Reddy, for giving me an opportunity to, be part of this very unique rapid fire CME on the occasion of World Hepatitis Day. And my special thanks to them for getting me connected with my teachers and all the stalwarts in hepatology. So the question I have been asked in this patient is that why did he develop cirrhosis? So briefly, I think if you look at the database, what we have in this patient is 45 years old gentleman who was chronic Hep B for 13 years and also had evidence of hepatic steatosis. Some of the things were not given to me when the case scenario was given, like I didn't know about his E antigen status to begin with. What was his status of hepatic fibrosis at baseline? is not clear from the details, but he definitely had hepatic stenosis. His BMI now is 29, which would fit into the category of obesity by the Indian definitions. What has been his average body weight in last 10 years, I'm not really sure. He was a poorly controlled diabetic. I'm presuming that he's non-alcoholic. And I did not get the details on his hypertension and dyslipidemia. But he was on a recover for last 13 years with partial biochemical response, I would say, because the information given to me is that his ALT continued to remain elevated. Though he had virological response in the sense that he was DNA negative. So I'm not sure why the anti-cover was continued for 13 years. So did he really achieve the end point? Could it have been, discontinued? I think let's not get into that. The question being asked is that why did he develop cirrhosis? So, and presently his LSM shows 14.5, which, anything more than 12.5, we will take it as evidence of cirrhosis. His CAP is 359, which suggests that he still has severe steatosis. He has mild ascites now and small varices. Only worry is that, even at LSM of 14.5, he's decompensating and developing varices, which usually would happen if somebody has what we call, the LSM of say 20 or 25 or even beyond. So anyway, now the answer to this question is that why did he develop cirrhosis is that because he had other risk factors, and the other risk factor which I said is he was obese, he was diabetic, which was poorly controlled, and then he was a hepatitis B, chronic hepatitis B. So when we look at the contribution of obesity, diabetes, and metabolic risk factors in general, they have been shown to be independent risk factors for fibrosis, cirrhosis, and liver cancer in general, and also including in patients with chronic hepatitis B, thereby suggesting that there is something known as synergistic effect of metabolic risk factors in patients with chronic hepatitis B. We also know that NAFLD is a hepatic manifestation of this obesity and diabetes and metabolic syndrome. So once you have chronic hepatitis B with fatty liver, or if you like to call it as NAFLD, this would obviously increase the risk of cirrhosis and liver cancer. So what is the mechanism behind this is, probably the fatty liver, which is adding on to the lipotoxicity to the hepatocytes, causing the release of various inflammatory cytokines and various fibrogenic cytokines, which probably are combined with the ongoing injury because of hepatitis B, is probably contributing to the augmented risk of fibrosis and cirrhosis. So I'm not going into the mechanism of this increased risk, but what I'm going to show you is some recent data on this. What I'm saying is that do they have increased this? I have picked up only 2 studies. And one is the study from Journal of Viral Hepatitis in 2019, where they had taken this 460 patients with chronic Hep B E negative patients, and around half of them were treated with oral nukes. And then they looked at that how many had fibrosis progression and regression. So the progression was seen in around 9% and 37% had regression. But importantly, when they looked at that, what were the predictors of fibrosis progression in them, other than no treatment with nukes, 2 important factors which came out were the presence of metabolic syndrome, 4.3 as the odds ratio, and hepatic steatosis around 8 times risk of putting them at a fibrosis progression. So we know that if you have metabolic syndrome, if you have hepatic steatosis in patients with chronic hepatitis B, your risk of fibrosis progression is much higher than somebody who doesn't have it. Almost similar study, but looking at the clinical events published last year in hepatology, large number of patients, around 1100 from US and Europe, and they had liver biopsies in all these patients, and they had documented around 17% of them having NAFLD, or even qualifying to be called as NASH, which means some inflammation and fibrosis being there, and majority having no fatty liver. Now they looked at the clinical events, which meant death, decompensation, transplant, or HCC. What they found was that those who did not have fatty liver, the clinical events were only 6% versus 15% in those who had NASH. And when they looked on multivariate analysis, I think they found that NASH and advanced fibrosis were associated with, the poorer clinical events or the risk of decompensation and the HCC in comparison to those who did not have NASH. No, I think this was the answer to the question which was, posed to me. But when I was looking at the literature, I just found that there are 2-3 more issues which probably are very, very important whenever you are talking about the occurrence of hepatitis B and the metabolic risk factors and hepatic steatosis. So one, I think if there are any postgraduates which probably they need to know is that when we talk about hepatic steatosis in patients with chronic viral hepatitis, in hepatitis C, we know especially genotype 3, it could be virus-induced hepatic steatosis. The virus can induce hepatic steatosis by causing various changes at the cellular level. The virus induces insulin resistance, but in hepatitis B, the predominant data would say that the hepatic steatosis is predominantly related to metabolic risk factors and not to the virus. That is number one. The second is, there's some emerging data, or I would say conflicting data, to even suggest that those who have hepatitis B infection, the risk of hepatic steatosis may even be lower in them in comparison to somebody who doesn't have hepatitis B infection. Secondly, there is some data, again conflicting, which says that if you have hepatic steatosis, your chances of having markers of hepatitis B, for example, the HbA1c positivity or DNA clearance, are also, diminished in patients those who have hepatic steatosis. So you will have less of DNA viral load, you will have more of HbA1c negativity if you are hepatitis B positive. And finally, there's some data to suggest that there could be some interplay between the hepatic steatosis and the, response to nukes, especially entecavir and the tenofovir. So I'll quickly show you some data on this. Regarding the first point, that the hepatic steatosis and hepatitis B is related to metabolic risk factors, I have picked up this meta-analysis of 17 studies, 4,100 patients with chronic hepatitis B. Overall hepatic steatosis in around 29%, which is almost similar to the general population. But important is, when they looked at the reasons for hepatic steatosis in this patient, and if you look at this, other than the alcohol and the male gender, these are all metabolic risk factors, may it be obesity, diabetes, glycemia, or triglycerides. So the message is that the hepatic steatosis in patients with hepatitis B are predominantly related to the host factors and not to the viral factors, number one. The second thing I said was that there could be data emerging that there could be a decreased risk of hepatic steatosis and dyslipidemia in patients with hepatitis B infection. These are the large number of studies which have shown that the odds of having hepatic steatosis is lower if you have hepatitis B infection in comparison to those who do not have. If you look at the odds here, they're all less than 1. Similarly, there is also data that there is the presence of HBV seromarkers, may it be DNA or may it be HbA1c, are lower, which means that you have more of DNA clearance and less of HbA1c positivity if you have hepatic steatosis. The time doesn't permit me to get into the details that what is the pathogenesis behind this, but again, there's a lot of work which has come up which says that if you have fat in the liver, this actually somehow would increase the body's antiviral response, especially by increasing the innate immunity and also by increasing the apoptosis, decreasing the autophagy, and by metabolic alterations, thereby, affecting the viral replication and decreasing the, the seromarkers of hepatitis B. On the other hand, if you have hepatitis B infection, this does, tend to improve your insulin sensitivity. And the major reason they are saying is probably because of the role of adiponectin and various other, but then I said the data is conflicting. The time doesn't permit me to get into details, but there's some data to say that you can have less of hepatic steatosis if you have hepatitis B infection. Finally, which I said is the interplay between these fat and the response to antiviral therapy. There's some data to say that the contact area between the hepatocytes and the drug is reduced if your hepatocytes are full of fat, thereby reducing the bioavailability of drugs like entecavir and tenofovir. But as I said, this is again conflicting, and the response to nukes in these patients can be, normal, or even it can be poorer. So So I have picked up this one meta-analysis of 8 prospective studies of 400 patients of chronic Hep B, 399 having, fat in the liver, and 688, patients having only Hep B without fat. And finally, when they looked at this analysis, that what is the kind of response, they found that if you have fat in the liver and if you're treated with nukes, the chances of biochemical response and virological response are poorer if you have fat in the liver. So I think, but as I said, the data is conflicting. We cannot really draw a major conclusion, but there's some evidence to suggest that yes, these patients can have poor response to antiviral therapy. So let me summarize, ladies and gentlemen, what I said. So the answer to the question that why did he develop cirrhosis is probably a combination of Hep B and the metabolic risk factors which he had, obesity and diabetes, which led on to the fat in the liver, and there was probably an increased risk of fibrosis which went on to cirrhosis. But obviously there are few things which we can't explain in this patient, because hepatic steatosis in this person looks like related to metabolic risk factors, because he had obesity, he had diabetes. Whether the point which I raised that hepatitis B patients can have reduced hepatic steatosis is not evident in this patient, because he continued to have fat in the liver. Rather, his CAP, even when he had significant fibrosis, was still 359. So this is not evident. The second thing which I said, again conflicting, whether they have the next HBV seromarkers, again is probably not really observed in this patient, though he was DNA negative on entecavir, which would happen, but his HPCG continued to remain positive. And whether the hepatic steatosis has anything to any role to play in the response to nukes in this patient, again I think probably the fat did not play any role, because he had good virological response. He continued to remain HBV DNA negative. Only thing is his liver disease has progressed, for which I personally feel these were the uncontrolled metabolic risk factors which did the damage to him rather than hepatitis B, but hepatitis B could have played some role. So I'll stop there, and thank you very much for your kind attention.
Thank you very much.
Thank you.
And then with this, we'll go on to Dr. Vivek Saraswat. Can you share your slides, Dr. Vivek? As you can see here, in the last one, 13 years was this been taking, and the question was that why was it taking for 13 years? We have here again at 10 years, a teacher has been taking. Vivek, please, can you?
Right, the next two cases
Yeah.
are dedicated to the memory. Oh, we don't have the slides. Wrong slides.
No, I think yes.
Dedicated to the memory of Dr. Dharamveer Datta. Can we have his slide, please?
Yeah, just give me a minute. I'll be with you. Yeah.
Dr. Datta died at the age of 47. 47 in 1981. What is this noise in the background?
Yeah, I hope you can see my slides now.
Yes, we are.
Yeah. I said he died at the age of 47 in 1981. Dr. Datta went to London to Royal Free Hospital to work with Professor Dame Sheila Sherlock, which is known as Regina Hepatica. He obtained his PhD there, and then he came back to PGI, where he headed the Department of Hepatology. In fact, he started the Department of Hepatology in PGI in 1971. His main research was in non-cirrhotic fibrosis and Budd-Chiari syndrome, which earned international recognition. He described arsenic consumption in Punjab as an important cause of NCPF. By doing various interventional procedure in Budd-Chiari syndrome, he described two types of Budd-Chiari: hepatic vein block and IVC block. Hepatic vein block having bad prognosis, and IVC block having relatively better prognosis. Unfortunately, he died at a very young age from a rare disease, Whipple's disease of the brain, diagnosed at the Institute of Neurology, Queen's Square, London. Okay, now we go to Vivek, your case, in memory of Dr. D.V. Datta.
Yeah.
Right. He's a 45-year-old male, high school science teacher in a village with no comorbidities. He's been taking entecavir for the last 10 years with excellent compliance. He's been having normal ALT and AST continuously with undetectable HBV DNA done thrice in the last 10 years, the latest one a year before. He has placed before his doctor, Vivek, is placed before you the following concern. He said, can I stop and take away, doctor, since it is too expensive for me? And then he's saying, someone suggested lamivudine because it's cheaper. And have you got anything new in the treatment of hepatitis B virus? Vivek, 3 questions.
Thank you very much, Professor Dilavri. Good evening to all the panelists. And a big thank you to Dr. Rao and Dr. Reddy for planning this excellent rapid fire session. I'll try and stick to the rapid fire format. And coming to the questions that have been posed, the information that has been provided about this patient is that he is 45 years old, no comorbidities, probably suffers from chronic hepatitis B and has been on entecavir for 10 years with good compliance to medication. In fact, his DNA is undetectable on different occasions. The questions have already been put. Can he stop entecavir? Can he switch to lamivudine? And are there any other options? However, data that are missing that would have been very useful to help to analyze this patient further is, does this patient have any evidence for cirrhosis? A liver stiffness value, a good ultrasound, details of liver function profile at this point would help to clarify this issue. Similarly, the E antigen status at baseline and the present E antigen status is not provided. And as well as it would be good to know after how many 10 years of entecavir, what has happened to his HBsAg status? Has his HBsAg lately been tested? And of course, while 1 year ago the DNA was normal, does it continue to be normal today? So these pieces of information would be useful, as would be information about the quantitative anti-HBs level. And I'll come to these points one by one in the next slides. Now, his first question is, can I stop entecavir? To answer this, sorry, I think, can we stop that? I'm getting Dr. Katie Shinoy is sharing the screen. Can you please stop that?
Round of it.
Yeah, okay. The questions that have to be answered is, can entecavir be stopped? Now, the answer to that would depend on the question of whether his surface antigen loss has happened over the period of 10 years when he has had this excellent compliance and undetectable DNA. If his S antigen loss has happened, which can happen in about 7 to 8% of patients over this period of time, then yes, entecavir can be stopped. And this is based on the EASL 2018 recommendations, which state exactly this, that leukocytes can be discontinued after confirmed HBsAg loss.
There's a lot of background noise from Shinoy.
Everybody else, mute, please. Everybody else, please mute.
The other important question here is, does the patient have liver cirrhosis or not? While one expects that starting with chronic hepatitis B, cirrhosis should not have developed, but we just saw in a few other patients, due to comorbidities and other factors, cirrhosis can be present. And if due to any reason, hepatitis B or concomitant cofactors, if there is cirrhosis present, then the general dictum is that a nucleoside analog should not be stopped because of the risk of a flare and resultant decompensation and liver failure. Now, if this patient has no cirrhosis and had been HBe antigen positive at the baseline, one would like to know whether E seroconversion has happened. Is it a stable E seroconversion, and has consolidation therapy for 12 months been completed, which would again have depended on monitoring data. Most of our patients, and this patient is one example, they are very good at following advice and taking medicines. But the doctor's advice as well as the patient's pocket may often not permit close monitoring. And so these data are not provided in this patient and are also often not available in your common clinic patient. But nevertheless, for us to follow guidelines and be rational in our decision making, it would be important to know, was he E positive at baseline? This also has implication on future treatment options that I'll come to in a minute. And if he were positive over this 10-year follow-up, has he seroconverted? And since 10 years of therapy, most likely he's been consolidated. If that is the case, then yes, we can withdraw entecavir, we can stop entecavir, and he'll need close monitoring for a flare. Again, about it in a minute. On the other hand, if he's not cirrhotic and he had E antigen negative chronic hepatitis B when entecavir was initiated, then one would like to know, and this has been 10 years, so it's probably the answer is in the affirmative, that yes, his DNA has been undetectable for 3 years. In that case, again, he is a candidate for withdrawal of entecavir therapy with close monitoring for flare, with weekly ALTs in the first few weeks, and then 4 weekly and 12 weekly DNA determination to see if the patient flares. And in these situations, yes, nucleoside withdrawal can be stopped. Now, coming to other options, if his entecavir withdrawal is attempted and doesn't work out, he relapses again, then these options may have to be considered, and or some of them will be introduced upfront. And these options are offering various forms of combination therapy for chronic hepatitis B. Now, these are what combinations are available for chronic hepatitis B. It may be a nucleoside plus nucleoside analog combination, or it may be a nucleoside with pegylated interferon being used. These can be used de novo, that at the very outset you start with a nucleoside analog and peg interferon, or in patients like this one who's on long-term effective viral suppression of nucleoside analogs, peg interferon alpha can be added on. Our patient is the latter category, and obviously de novo is not relevant to him. On the other hand, in a patient on long-term viral suppression of nucleoside analog, you add a second highly potent and a high threshold of drug resistance, a second nucleotide analog, only if there is a long tail. That is, there is a persistent low-level viremia despite effective nucleoside analog therapy. Viral load has dropped to a low level, maybe 2 log, 3 log, in that range or below, but is not become undetectable after 12 months or 18 months or longer of the potent analog therapy. And then there are some data that yes, a nucleoside analog can be added. Doesn't apply to our patient because he's aviremic for the last 10 years according to the data provided. So he does become a candidate for nucleoside analog with peg interferon alpha combination therapy, which may be used either in an add-on mode or a switch to the newer to peg interferon, which is all that can be done since he's already on nucleoside analogs. So let me quickly take you through the various types of combination therapy that have been tried in chronic hepatitis B. And the duo I've talked about simultaneously or de novo initiation of nucleoside and pegylated interferon, which doesn't apply to our patient. The add-on therapy can be a nucleoside-based therapy, which he's already been on, and you can add on pegylated interferon in these different ways at the fag end, upfront preceding nucleoside analog, or sandwiched in between the course of nucleoside analog therapy. While if a patient was on a pegylated interferon therapy, which doesn't apply here, these are the ways you can combine nucleoside analogs as shown in this graphic. On the other hand, switch therapy is when you are using nucleoside analogs and pegylated interferon is added on either after withdrawing nucleoside analog or after a brief overlap with pegylated interferon with nucleoside analogs. So what are the results of this therapy? In this slide, I briefly summarized data of add-on therapies, and this is again data.
We don't see the slides.
We are not able to see the slides. We are only about hearing.
Well, I mean, they are showing on mine. I'll just see if it is for some reason stopped sharing. I am not really.
Okay, you can go ahead. Go ahead with
Hey,
No, I'll
carry
say
on.
that
Go ahead with the-
for some reason it got unshared and will now come on again. Can you see it now?
Yeah.
Yes.
Okay. I think for some reason it got stopped sharing. And
Okay,
I
anyway.
hope I didn't miss. Do you want me to go back to any
No,
slides?
no,
or we
no.
can-
Summary will be important.
Yeah. So to summarize, these are some data for add-on therapies, and these are all available for e-antigen positive chronic hepatitis B. There are not too many data, and they are not very effective in e-antigen negative chronic hepatitis B. In this slide, I've shown the data from 7 different trials, mainly in e-positive patients, although there are 1 study with e-negative patients also included. While e-antigen seroconversion has been shown to improve with this add-on therapy, there is only a modest improvement up to about 8%, up from 1 to 2% in terms of S-antigen seroclearance. So yes, there is some role for add-on therapy, but not a huge role. By adding 48 weeks of pegylated interferon, yes, S-antigen clearance rates can improve. With regards to switch therapies, this slide shows the summary of 6 trials, basically 4 trials in which towards nucleoside analog, we have added pegylated interferon therapy in e-antigen positive chronic hepatitis B, and this is the status at the initiation of antiviral therapy. This is data which is quite encouraging in a study in which pegylated interferon for 48 weeks was used in a person on long-term tenofovir, and there is improvement not only in e-antigen seroconversion rates, but there is also improvement in S seroclearance, surface antigen seroclearance rate, which may go up to about 18% with the combination use of pegylated interferon when you switch after having used nucleoside analog. So to summarize, a combination of pegylated interferon and tenofovir is the most promising according to published data. Switching therapy is better than add-on, although head-to-head trials which clearly show this result are not available. But whatever few literature studies show slightly more promising results for switching from nucleosides to pegylated interferon in terms of S-antigen seroclearance. However, one needs to bear in mind that at least the current guidelines from the ASLD and the EASL do not recommend any form of combination therapy, whether de novo, add-on or switch therapy as yet. So I'll come to that also in a minute. So coming back to our patient is a chronic hepatitis B, person with chronic hepatitis B who's been on long-term HBV suppression on entecavir, which has been effective. That is, the DNA is undetectable. So the entecavir withdrawal can be attempted, and regardless of whatever was the e-antigen status, because he's been negative long enough, almost for multiple years, although I like to confirm it with a recent set of tests that I spoke of in the beginning, a recent DNA also. And a close monitoring of ALT and DNA in the immediate period following withdrawal for up to 3, and the relapses may actually happen up to as long as 6 months after withdrawal. So the immediate follow-up is important to see that he doesn't relapse on withdrawal. On the other hand, he is also a candidate if he were e-antigen positive chronic hepatitis B at baseline to switch to or add on pegylated interferon for 48 weeks. Whether after attempting entecavir withdrawal or even directly, this can be added on. The HBS quantitation data suggests that if at the point of adding interferon, if his baseline HBS AG quantitation is below 1500, some studies say below 1000 IU per ml, there is a high chance of surface antigen loss, almost up to 20%. And if the viral load is the HBS AG quantitation is higher, 20,000 units or higher, then there are certain stop rules after 12 weeks of pegylated interferon to look at the response in DNA and the antigen surface and the HBS AG level to decide whether you can continue in the e-antigen positive patient, or you should consider it infructuous therapy and withdraw pegylated interferon. In the e-antigen negative chronic hepatitis B, one may do a trial of add-on or a switch to peg interferon, aiming to treat for 48 weeks, but reviewing at 12 weeks. And since the rates of S antigen loss are quite low with e-antigen negative chronic hepatitis B, it would be good to follow the stop rules, and if there is no decrease in the surface antigen level or in the DNA, then one can withdraw pegylated interferon at 12 weeks. However, we started this whole discussion with the statement that the patient cannot afford continued entecavir. He wants a low-cost option, and pegylated interferon certainly is not a low-cost option, and it needs to be combined with monitoring. So, and the benefits, as I have shown, are not huge, at least for the 48-hour treatment, and newer pipeline drugs are still some distance away. So this is the best option that one can offer, but does not appear to be something that may appeal to a patient who is looking at a very tight pocket. Similarly, shifting to lamivudine, although it is cheaper, cannot really be advised to this patient. Withdrawal of entecavir trial is probably his best option, and hope that it works for him. But because it is no longer recommended as a first-line treatment, because it is not a potent inhibitor, it has a low threshold to the development of mutations and resistance to lamivudine can compromise the efficacy of other nucleoside analogs. So I don't think we can recommend shifting to lamivudine. This is the EASL recommendation. And a quick look at the stop rules for E antigen positive chronic hepatitis B according to the genotypes of B virus for E positive. And for E negative, you look for a decline in surface antigen level. If there's any decline, you continue in E antigen positive, E antigen negative subset. Genotype D only is referred here. This is the most responsive. If there is no decline in HBsAg level, you look at the DNA level. And if there is a more than 2 log decline in DNA level, then one can still continue with pegylated interferon for 48 weeks. If there is less than 2 log decline and no decline in HBsAg level, then you can stop therapy.
Thank you.
That's all that I have for you.
Thank you very much. Dr. Mahesh, can you go on to share your slides? And to be very brief, this is a 48 years female bank employee who has been taking prednisolone for some dermatological condition. And over to next slide, please. And then this patient came with the problem of an acute hepatitis like situation clinically, and she was E negative, and her platelets were 85,000, and ultrasound showed that the increased echo texture and the mild splenomegaly. Dr. Mahesh, how do you go about, is it an acute hepatitis or is it a reactivation in a patient who has been on prednisolone? Over to you, please.
Thank you, Dr. Rao, and good evening, everybody. Thanks for having me in the midst of hardcore eminent hepatologists. So, as I think there will be some repetition, Dr. Kaushal Madan has already addressed this point to some extent, but I think this needs to be further focused and further emphasized that when a patient with hepatitis B presents with acute icterus, 40 to 50% of them are due to reactivation. Now, we all know about these 5 phases of hepatitis B, chronic hepatitis B, and the present nomenclature as compared to the old terminology. And when we talk of reactivation, we are talking of reactivation in phase 3, phase 4, or phase 5. While this reactivation can be spontaneous, often it is caused by some immunosuppressive medications, including corticosteroids. It can be caused by antiviral therapy. It can be caused by superimposed infections with other hepatotrophic viruses. And sometimes it can be interaction with HIV infections. So why it is important to differentiate acute hepatitis B from reactivation? This is an ongoing dilemma, and I'm sorry, even after my talk, this dilemma will continue. Importance is because acute hepatitis B, 90 to 95%, as we know, resolve spontaneously, and no treatment is required in majority of cases. Whereas in chronic hepatitis B with acute exacerbation or reactivation, this can cause decompensation, and treatment is almost always warranted. So how do we differentiate? What's the clinical and biochemical parameters which can help us in differentiating acute hepatitis B from reactivation? If there's a known positive history of hepatitis B, it will help. If there's evidence of cirrhosis, it will help. If the time of exposure is clear, whether it's recent or distant, it will help. If there is a precipitating factor, as was present in this patient, immunosuppression, it can help. And alpha-fetoprotein has been found to be some help. There may be a modest increase in chronic hepatitis B with acute exacerbation. But overall, liver function test does not help us in differentiating acute B from reactivation. Now, these are important parameters. Unfortunately, we do not have in this patient NT-hBC IgM data being given. But this is a very important parameter to differentiate acute B from chronic hepatitis B with reactivation. positivity is present in majority of acute, but can also be seen as mentioned by Kaushal in 75% of B as well. But the titer is important. While in acute B, 78% will have a titer of more than 1000. This high titer is seen in chronic B with reactivation only in about 30%. People have also used sample to cutoff ratio, being a cutoff value of 10 to 20, and this is higher in acute hepatitis B and is usually lower in reactivation. The anti-HBC IgM subtype of molecular weight, higher molecular weight is seen in acute viral B compared to reactivation. The HBV DNA level is very important. It is usually low in acute viral hepatitis B as mentioned by Kaushal, but is high, and people have used different cutoff values in terms of copies more than 10 to the power 5, in terms of international units more than 15,000. HBe antigen as expected would be lower chance in acute B and is higher chance in chronic B. And in anti-HBe antibody positivity will be seen only in about 20% in acute and about 83% in chronic. By combination of anti-HBe antibody, anti-HBC IgM of less than 1000, and HBV DNA of more than 10 to the power 5 copies will demonstrate that it is likely to reactivation with a positive predictive value of 98% and negative predictive value in some series of 100%. So this is some of the recent data from India, which have shown that the ROC curve is very suggestive in differentiating both for anti-HBC IgM and HBV DNA. And for chronic hepatitis B with reactivation and HBV DNA of more than 15,000, it has a sensitivity of 78%, specificity of 48%. Now, some of the other parameters which may help, FibroScan, not in the acute situation, the ALT must come down to less than 2 types of the upper limit of normal, and then one should do this 2 months after this, and then the FibroScan can help you in finding out whether it's a chronic or an acute. Histology can be useful, but sometimes because of INR being high, you may have to do a transjugular, and hepatitis B surface antigen will be helpful only if you follow these patients for at least 6 months. So let me come back to this case. This is the parameters which have been told to us by Dr. P.N. Rao. And if I look at the various parameters, the one in the orange does not help us in differentiating acute from chronic. One in green, platelet count being low, 85,000, does indicate there is a chance of chronicity. Anti-HBe positive does indicate that this is more likely to be chronic with reactivation. Ultrasound showing liver increased ecotexture with splenomegaly goes in favor of reactivation, but maybe they are even in acute as we discussed. Presence of a history of prednisolone being taken recently for last 2 months goes more towards reactivation than towards acute. But we cannot be certain because in this case, HBV DNA is not very high, 3,600 international units per ml. So this is a pointer more towards acute as was discussed by Kaushal, but can happen in chronic also. So overall, we are still confused after these parameters. Unfortunately, anti-HBC IgM parameters should have been available to differentiate. It could have helped us. An upper GI endoscopy would have helped us. And of course, some patients will require histology. When you are in doubt, as Kaushal mentioned, you start antiviral therapy and follow up these patients. If the patient becomes negative very soon with HBsAg, and if the FibroScan does not show any signs of chronicity or fibrosis, or it shows the signs of fibrosis on follow-up, when the SGOT, SGPT comes down, ALT, AST comes down, can be helpful in differentiating. So if I have to put my bet in this particular patient, I'll be thinking more of reactivation than acute viral hepatitis B and will start the treatment. This is my last slide. So to differentiate acute viral B from chronic B, you need to take detailed history, look for evidence of portal hypertension, anti-HBC IgM, HBV DNA combination, look for HBsAg, histology, and follow up these patients with hepatitis B and transient elastography. Alpha-fetoprotein and HB antigen may also help. Thank you very much.
Thank you very much. As you can see that I purposefully held up some of the information which you wanted to do, which you wanted to very much have, because I wanted the people to know how to approach the patient, what to ask for in these situations, right? With this, we'll close the session. Dr. Dilavari, for your closing remarks before we go on to, there are several questions are there, but time does not permit. We have overshadowed over by about half an hour, which is not permissible. You can wind up with your final comments. I thank very much all the speakers.
You've taken up part of my job anyway, and I really enjoyed these sessions. I learned myself quite a lot, and I think Mahesh has done a wonderful job by differentiating acute versus subacute about the reactivation, and I enjoyed it. It was very, very well done session. Thanks to you, Ian.
These are all practical questions which we come across day in and day out. That is, the Ajay D'Souza has said that how to go about and then increased progression of these patients, and Kaushal has told about the HBsAg positivity and autoimmune hepatitis, how to differentiate whether it is there or not. We have autoimmune negative markers are there, and then to complicate the issues, and also how difficult sometimes to start the treatment, and in these patients when to stop the treatment is also a question which has been, some of these things have discussed, and wonderfully well by Dr. Mahesh Goenka, how to differentiate between reactivation and then acute. These are all the situations which we come across day in and day out, purposefully, and then all of you have done an excellent job. With this, over to Dr. Koshi for taking over the third session. Over to you, Dr. Koshi. And I would request Dr. Akash Shukla will start sharing his slides. Thank you, all of you.
Thank you, sir. Thank you. Bye-bye. Thank you.
Can I have the next slide? Dedication. Doctor, this first case is dedicated to Dr. H.G. Desai. Dr. H.G. Desai, like all the other three whom we dedicate this session to, academics, very personal touch for the patient, and a gentleman. He has more than 200 publications, and one of his classic papers was on classification of chronic gastritis. And he is the one who started DM in gastroenterology in Mumbai in 1986. So with this few words about Professor H.G. Desai, I'll request Akash to start the case presentation.
Yeah.
The next slide.
Thank you.
Yeah. 53-year-old male, BMI just above the Asian limits, no comorbidities, was given blood transfusion for a fracture 26 years earlier, and in a master health checkup, he was found to have bilirubin upper limit or just above normal, AST which is twice normal, ALT 5 times normal, and alkaline phosphatase which is near normal. We have platelet which are normal, is HBsAg positive, anti-HCV negative, and HIV negative. Ultrasound shows increased echo texture in the liver with mild splenomegaly. Other components of the health checkup are normal. Now over to Akash to discuss this case. HBsAg positive, AST, ALT elevated.
Thank you, sir. At the outset, I would like to thank Professor P.N. Rao for inviting me for this wonderful meeting and this interesting case. So here is a 53-year-old gentleman who had a risk factor of blood transfusions around 26 years ago. And now he has come hepatitis B positive as well as tested positive for anti-HCV antibodies. And the ultrasound shows an increased ecotexture of liver with mild splenomegaly, with the platelet count which is borderline, although in the normal range of 212,000, but significantly elevated AST and ALT, with rest of the liver functions being normal. So why should we know about the co-infection of hepatitis B and hepatitis C? Patients who have co-infection have a higher rate of cirrhosis, a risk of 44% as compared to 21% of patients who have only hepatitis B, and increased risk of decompensated liver disease, almost 24% as compared to 6% who are mono-infected with hepatitis B. In another study, when compared with patients who are mono-infected with hepatitis C, the risk of cirrhosis is much higher with co-infected, In this study, 95% versus 49%, and decompensated was 37% versus 0% in this particular study. So there are contradictory studies as well, which have shown that there is no extra risk, but these two studies are the ones which have shown a distinct difference in those who have a co-infection. Also, another study showed that those who are co-infected, that actually is the greatest predictor for developing HCC in patients with cirrhosis. And this risk was quantified to be 6.4 per 100 person years in those who are co-infected, as compared to 2 in HBV and 3.7 in HCV mono-infected cirrhotic patients. Now, what are the viral interactions between Hep B and Hep C which will determine how we... Most co-infected patients have a hepatitis C which is active, that is HCV RNA is high and the HBV DNA is low. There is inactive HBV replication and this is called as HCV dominance. But there are some patients who have Hep B dominance, those who have a high viral load of hepatitis B but undetectable HCV RNA. There is also an entity which is rare, but where there are alternating phases of dominance of one virus over the other, and that is called as alternating dominance. And both the virus may be active and both the viral loads may be significant, what is called as codominance. Now, different studies have put the proportion of this co-infected dominance to different levels, but most of the studies have shown 60 to 70% of patients will have a Hep C dominance. This was very important when we were dealing with pegylated interferon as the therapy for Hep C, because we had to decide whether we need to treat Hep C or Hep B or both. So coming back to our patient, a person who is HBsAg positive and anti-HCV positive, the next step would be to do HBV DNA quantitative and HCV RNA quantitative. However, we also need to know whether this patient has fibrosis, cirrhosis. So we would do a fibroscan or an MR elastography to further find out the stage of fibrosis. Also, we would do an alpha-fetoprotein along with a dedicated liver ultrasound as a screening modality for screening for HCC. Now, in the era of DAs, this dominance has become less important, but what has become more important is the reactivation of hepatitis B after starting HCV treatment. So the first three studies by Gain, Doi and Kawagishi, which looked at patients who were co-infected, did not show any clinical HBV flares. But subsequent studies have shown that clinical hepatitis can happen, like the one shown by Liu et al. For the first time, 5 patients with clinical hepatitis out of 70 patients. And then subsequently, most of the studies have shown that there could be clinical hepatitis, and Ye et al. For the first time showed that this can give rise to actually death and liver failure by Wong et al. So over a period of time, we have realized that even if the Hep B is inactive initially, on starting treatment for Hep C, the Hep B can become reactivated, and it can not only cause a biochemical flare, but it can also cause a clinical flare, including liver failure and mortality. So is there a role of prophylactic therapy for Hep B, even in the absence of high viral load for Hep B, once you are starting a patient on hepatitis C therapy? So the different guidelines again differ from each other. All of them agree that we should test for HBsAg in patients with chronic hepatitis C, but whether a prophylactic use of NUC should be done at the start of DA in such patients, ASLD says no. Monitor DNA and ALT every 4 to 8 weeks and for 3 months post DAA. EASL says yes to prophylactic use, concomitant NUC prophylaxis until week 12 post DAA, and APASL is more discreet and appears to be the most scientific. It's indicated for patients with advanced fibrosis, cirrhosis, or previous HCC. And for patients without the above indications, they have given the option of both prophylactic use of nuke or close monitoring, but a follow through up to 24 weeks after the end of DAA is recommended in all of these patients. So how do we decide the treatment in our patient? If the HCV RNA is positive, HBV DNA is greater than equal to 2000 international units per ml, then we would probably give our patient DAA plus a nuke. Although you can say, as per the ASLD guidelines, you would observe the patient closely and not start the nuke. HCV RNA positive, DNA less than 2000 international units per ml, DAA plus either use a nuke or a DAA with a very close monitoring of the HBV DNA and biochemical profile. HCV RNA negative, HBV DNA more than 2000 international units in our patient, we would use a nuke. HCV RNA negative, HBV DNA less than 2000 international units per ml, we would do a close monitoring and look for other causes for the high enzymes in our patient, like probably NASH, which has been discussed beautifully by the previous speakers and Dr. Ajay Duseja. So last but not the least, whatever the case scenario in our patient, this patient would need a HCC surveillance every 6 months with an alpha-fetoprotein and a dedicated ultrasound of the liver. This has to be continued lifelong, and please do not forget the family screening for this patient. Also, contact tracing for all the close contacts where he could have been transmitted, family screening and vaccination for hepatitis B should be done. Thank you very much.
Thank you. Thank you very much, Dr. Akash, for your excellent and then very practical advices which have been given in patients who are HBsAg positive and then HCV negative. With this, we'll go on to Dr. Shalimar, who has already started shared his slides. Over to you, Dr. Koshi.
Thank you. I'll first speak on, can I have that slide, please? Shalimar, keep that slide on. Yeah, thank you. I would like to dedicate this case to Professor S.R. Naik. Professor S.R. Naik, we knew each other more than 40 years ago. When I first joined PGI, he became a good friend, and Dr. P.N. Rao was also there at that time. And he had many achievements, which I cannot enumerate all. But I think the greatest achievement, at least in my mind, was his starting the Department of Gastroenterology at SGPGI in Lucknow. And that's a testament to his vision and his capabilities as a teacher. His first DM student from Lucknow, Dr. Deeman, is now the director of SGPGI. I think it's a great credit to Professor Naik. With this, I open the case to Dr. Shalimar. This is a 30-year-old IT professional who was being investigated as part of a fertility issue. HbSAg, LFT and ultrasound were normal. And she probably, fertility issue, I don't know. Anyway, he has a few questions. During a health camp by an NGO 10 years ago, he was given hepatitis B vaccination. But he does not remember if he has taken all 3 doses. And his question to Dr. Shalimar is, does he have to take all 3 doses again? Or does he need to take only 2 vaccines, 2 doses? Secondly, is there any new vaccine for hepatitis B? Over to Shalimar.
Good evening, everyone. At the outset, I'd like to thank Professor Rao and team AIG for inviting me for this rapid fire question session. So for the hepatitis B vaccination, the standard recommendations includes 3 doses, which are given at the interval of 0, 1 and 6 months. In specific situations, we give 4 doses, like in patients with chronic kidney disease. It's important to say that it's safe in all age groups. And when we say the vaccination is protective, that means we are referring to an anti-HBs antibody titer of more than 10 international units per ml. We also know from literature that these antibody titers wane off with time, but still, even if they are less than 10, they are protective against hepatitis B virus infection. What we know from data is that in individuals who are less than 40 years of age, even a single dose of hepatitis B vaccine gives it's a protection of almost 50%. 2 doses gives us protection of 75%, and 3 doses almost 90%. Important to state out here are the predictors of non-response or reduced responses. That includes diabetics, males, individuals who are obese, cirrhotics, those who have tobacco smoking, HIV, CKD, alcohol use, chronic hepatitis C, advanced stage and celiac disease. So if your patient has any of these, the response rates to vaccinations may be less. We've got single antigen vaccine, we've got combination vaccines. Combination vaccines include those which are available with combination with other vaccines like DPT, polio, and with hepatitis A virus. The brands available in India are multiple. The doses are different in children and adults, and doses are even higher in those patients who are on hemodialysis and immunocompromised patients. So do we test for post-vaccination? Do we test for antibodies? Generally, no, it's not recommended. It's recommended in only specific situations like infants born to hepatitis B surface antigen positive mothers, healthcare workers who are at continuous exposure and can be at risk for developing a hepatitis B virus infection, individuals who are on hemodialysis, who are retroviral positive, or those who are transplant recipients or are on chemotherapy, or partners of patients with hepatitis B virus can be tested and assessed whether they need any kind of intervention or not. So, if your patient has no response, which is defined as anti-HBs antibody titers, which are less than 10, which may happen in 5 to 15% of patients, test for HBs antigen positivity. Make sure that antibody levels are tested after 2 months of the last dose. So what do? We either use a different brand of vaccine, we use 3 doses or a 2-dose combination, or give a booster. Any one of these would be associated with another 30 to 50% response rate. If a person gets exposed in the meantime when he's a non-responder, consider hepatitis B immunoglobulin and vaccine in combination. So the strategies to improve efficacy include use a different brand of vaccine, increase the dose, or use an intradermal, which has been shown to have a better response as compared to an intramuscular injection. So as stated in our case, somebody who has missed 1 dose, what do? Give the next dose ASAP. Give the 3rd dose at least 2 months after the 2nd dose. If our patient has missed the 3rd dose, give it as soon as possible. The belief that interval between first and doses may have an effect, what the data suggests is that it does not reduce the efficacy but may increase the level of protection. So longer the duration is probably more beneficial to the patient. So if a patient has missed any dose, do not restart all the doses again. Just start from where he is already left and then continue with the remaining doses which are pending for that particular patient. Booster doses, not recommended in patients who have a normal immune status and those who've been vaccinated. Consider in special situations, as highlighted in the previous slide, those who are on hemodialysis or those who are immunosuppressed, if the antibodies are less than 10 MIU per ml. So on the vaccine front, what's new? Yes, we are looking at some new interesting data coming up. A new vaccine, which is Heplisav single antigen vaccine, which is recombinant with the CpG, which binds to the TLR and activates the immune system, has been shown to be of much better seroprotection as compared to the single antigen vaccine, that's the Engerix. So you can see a significant difference in the anti-HBs antibody titer among those individuals who are between 18 to 55 and the other problem group which doesn't form antibodies, that is 40 to 70. Heplisav has been shown to be much better than the Engerix. 2 doses recommended for individuals above 18 years of age. Interesting study published 2 months back in Lancet Infectious Disease. Tri-antigenic vaccine as compared to monoantigenic hepatitis B virus vaccine shown to be much better. So we've got something to look forward in this space in the near future. So coming back to our patient, do I recommend again 3 doses? Absolutely no. 3 doses are not required. And is there a new hepatitis B vaccine? Yes, we've got new hepatitis B vaccine in terms of Heplisav and tri-antigenic vaccine. So that would be my take for this patient. Thank you.
Thank you. Thank you very much for your very, very practical advices for the people. I would now request Dr. Anand Kulkarni to go on for the start his sharing his slides, please. Over to you, Dr. Koshi.
Okay, thank you. This case discussion is dedicated to Dr. Deepak Kamarpukar. He was a very active member of the Indian Association for the Study of the Liver. He was a former treasurer, a secretary, and a president of the IMASF. He was also one of the first Indians to be made a fellow of the American Association for the Study of the Liver, the AASLD. And he had many publications, clinical predominantly. But to me, he will always be remembered for having started the series called Best of AASLD Meetings, where the key players of the AASLD of Indian origin would come and present the AASLD highlights at an Indian center where hundreds of Indian doctors could attend and get the best of AASLD. And this meeting is now carried on by Professor S. Kesari. So with this about Deepak, I would request Dr. Kulkarni to show the first case slide. It's a 50-year-old male diagnosed to have NASH, related decompensated cirrhosis, child's C, MEL 30, also known to be a diabetic since 20 years, has been listed for a liver transplant, cadaveric, and he wants to know 3 things. Can he take the vaccine for COVID? And there are different brands now. Can he undergo liver transplantation during the pandemic? And thirdly, what are the consequences post-transplant if he gets a liver before completing the COVID vaccine schedule?
Thank you, sir.
Dr. Anand Kulkarni.
Great honor to be amongst the greatest of the greats of India. So, without wasting time, why he needs to be vaccinated? Before answering whether he needs vaccination or not, we have found that the risk of COVID infection in chronic liver disease patients is similar to that of the general population. And non-cirrhosis patients, that is chronic liver disease patients, they might be having a lower risk of developing severe COVID-19. But cirrhosis patients, as shown in a study by just known Bajaj and Gut, that they are at increased risk of mortality, and they have symptoms similar to that of normal individuals. However, 50% of these individuals can also have cirrhosis-related symptoms, and they can present with either worsening of jaundice, ascites, or encephalopathy. COVID can also lead to acute and chronic liver failure, which we have shown that they present with higher number of patients presenting with ascites, encephalopathy. They have higher bilirubin, higher creatinine, renal injuries, requiring longer stay of hospital, and also have a high mortality compared to those who did not develop ACLF. They have 30% mortality. Hence, he needs to be vaccinated. Yes, he needs to be vaccinated. Global Hepatology Societies now recommend that every patient of cirrhosis, chronic liver disease patient has to be vaccinated. But how is the vaccine response? What are the adverse events in chronic liver disease patients? This is our preliminary data, which is still unpublished. What we have noted is compensated cirrhosis patients have a good response. The neutralizing antibodies is around 1085 compared to decompensated cirrhosis who have a 9081 units. And liver transplant patients, only 8 were there. they have a pretty lower response compared to the other groups. And what we noted on the other hand, were adverse events related to post-vaccination. Most of them were easily tolerated. There were no other major side effects. Few side effects such as arm pain, fatigue, fever, and other symptoms were noted. In others, most often it was development of either functional GI disorders or pain abdomen. And post-vaccination, COVID developed in around 5 patients in chronic liver disease patients, and all of them had mild disease. So vaccines are safe in cirrhosis, decompensated and compensated and transplant recipients. Though the response is little lower in the transplant recipients, they must be vaccinated. So can he undergo the transplant during the COVID-19 pandemic? Yes, we have shown that we had analyzed around 10 patients who were awaiting transplant and they got infected with COVID-19, and their MELD increased significantly in around 4 patients. 4 succumbed to pre-transplant to either COVID or the worsening liver disease. Out of these 6 patients who were transplanted during the pandemic, 4 underwent transplant after 2 weeks, and the rest 2, since they were stable, we transplanted them later after around 4 weeks. Can he undergo transplant during the pandemic? Yes, he can undergo transplant, provided he satisfies this criteria. When should we transplant? Basically, if the patient candidate alone is positive, we check the RT-PCR and perform a CT screening of the chest and antibody testing at 14 days. If RT-PCR is negative, CT scan is normal and has only IgG and is asymptomatic, we proceed with transplant. On the other hand, if the PCR is positive or the CT is suggestive of active disease, or the patient has an IgM antibody or is symptomatic, then we wait for another 2 to 3 weeks. On the other hand, if the donor is positive and the candidate is stable, then we wait for 4 weeks. If the donor is positive but the candidate is worsening, then we continue with the same protocol, that is, we recheck for RT-PCR at 14 days along with CT scan and antibody testing. So transplant can be done safely during the pandemic, provided he is asymptomatic, CT is negative, and also has no antibodies or only IgG antibodies. So the next question is, what are the consequences in the post-transplant period if he gets the liver before completing vaccine schedule? So the ASLD guidelines recommend that for LT candidates, vaccination against COVID-19 should proceed even if LT is likely to occur before the second vaccine dose can be administered. The second dose of vaccine should be given at the earliest appropriate interval after transplant, that is 6 weeks after transplant. For other patients, for post-liver transplant, it is recommended to give vaccination after 3 months, at the time when they are on the lower side of the immunosuppression and also off of the other prophylactic antibiotics. For patients who have already received 1 dose of vaccine, it is recommended to give at least 6 weeks after the transplant. So LD candidates with chronic liver disease should receive a COVID-19 vaccine prior to transplantation whenever possible to help ensure an adequate immune response. This is according to the guidelines, and also we have shown that patients who underwent transplant had pretty lower antibody response post-transplant because of the immunosuppression, while those who were decompensated cirrhosis and cirrhosis, they had very good vaccine response. So what will happen if the patient gets, this recipient gets infected in the post-transplant? We analyzed around 18 articles and 1500 patients who underwent transplant during the COVID-19 pandemic. The mortality was comparable between the LT and non-LT patients. The odds ratio was 0.8 and the p-value was insignificant. There was also no significant difference in mortality between those who infected within 1 year of the transplant or in the later part of the transplant. That is, time from transplant to infection did not matter, did not change the outcome of these patients. Furthermore, we also found that only 23% of these patients developed severe COVID-19 infection. And the cumulative incidence of graft dysfunction. Graft dysfunction here, what we mean is acute cellular rejection. There are 2.3%. 2 out of 100 will develop graft dysfunction if they get infected post-liver transplant. So what will happen if they get transplanted? Infected, they have similar outcomes as compared to those of non-transplant patients. So the key message from this basic patient who is a NASH-related decompensated cirrhosis, he has a risk of infection similar to that of any other general population. So he needs to be vaccinated. There is no doubt vaccines are safe for both chronic liver disease patients and liver transplant recipients. And by chance, if he gets infected unfortunately, if he gets infected, if he develops acute on chronic liver failure, he may have a poor prognosis. Thank you.
Thank you very much, Dr. Akash, Anand Kulkarni. With this, we'll come to the last session, in this session and also in this series, by Dr. D.N. Reddy, and
We have the slide.
Over to you, Koshi.
Can we have the slide? Case
Yeah,
slide?
he's coming. The slide is coming.
Obviously, Nagi Reddy is going to discuss the endoscopy.
Yes, of course, you are correct.
Can we have the slide, please?
I don't know anything about hepatology.
No.
My brain, I can't take any hepatology. It's too small. Because endoscopy is mechanical, it's okay. Slide, no? Slide. Slide comes from where?
From here. Yes.
Okay.
Okay. Oh, no, the slide, case slide. The one before this.
No, I'll read out of that one. The same
Okay.
thing which you are supposed to. 50 years male, diabetic for last 10 years. He is an obese person. He was detected to have an inoperable carcinoma, head of the pancreas with an obstructive jaundice. He was COVID negative and is being listed for a palliative biliary stent, SEMS. And during this one, he has been detected to be HCV antibody positive. And I would like to ask Dr. Reddy, what are the precautions to be taken? Do we have to regularly screen the patient before an endoscopy session? I think he would like to take up these questions. Over to you, Dr.
Thank you, Dr. Pirla, for again organizing this webinar. The first thing is this patient is HCV antibody positive. Now, if we look at all the guidelines that are there from several societies, ASG, ESG, and so on, and the World Endoscopy Organization, the guidelines do not suggest routine screening for HCV or hepatitis B before doing endoscopy procedure. The reason why these guidelines came up is that the chance of transmission of these infections during endoscopy is very minuscule, especially proper protocol for disinfection of the endoscope is followed, and therefore there's no need to check all our patients for, although several years back we would do that, but now there's no need. Now, regarding this particular patient, HCV antibody is positive, but what would be more important in terms of knowing whether it's going to be infectious to the next patient and so on would be to actually do an HCV RNA quantitative study. We don't have this here, but what I would specifically look for before I do a procedure in this patient is to actually check for HCV RNA quantitative test to see what is the chance of transmission and what precautions that the endoscopists would have to take. There's specifically the procedure that I'm going to do, an ERCP, which involves disruption of the mucosal membrane, and therefore the chance of transmission of infection, if it's carried through either the endoscope or accessories, would be fairly significant, which means that the instruments that we are going to use have to be either sterilized or undergo high level disinfection. The third important factor in this case, of course, is protection of healthcare personnel who is actually doing the procedure. The problem with endoscope, especially with ERCP scope, is the tip of the scope is very complex, very difficult to disinfect completely or to clean it completely. So several guidelines have been put, and now what is happening in the recent year is that ERCP tips are becoming disposable. You can take out the ERCP tip and put in a new tip, and that's what we're doing more frequently to avoid this infection. Nevertheless, it has been shown very clearly that in patients, when you're doing the routine procedure, not only ERCP but endoscopy, colonoscopy, and so on, if you follow the normal norms of disinfection, that is 20 minutes glutaraldehyde or peracetic acid, it almost 100% clears off the virus. Chance of transmission is not there. Especially if you use high-level sterilization with ETO for reusable accessories and of course disposable accessories, then the level comes down. Several years back, a very interesting study was done by Jean-Francois Rey, who's the past president of WHO, where he took patients who were confirmed, 39 patients who were confirmed with hepatitis C infection. HCV RNA levels were very high, did endoscopy in them, and then of course checked the biopsy channel and the biopsy forces they used to do a biopsy in the patient, and found that 30% of these patients were positive immediately after the procedure, and then subsequently disinfected the endoscope and of course used disinfection or sterilization of the biopsy forceps, and then found that 100% were free from infection. It shows that the routine methods of sterilization and disinfection gives 100% protection. Of course, you can't do these studies nowadays. This was 20 years back. You can't do this nowadays. But it clearly showed that the transmission of hepatitis C virus is extremely low when you follow, or almost zero when you follow the normal methods of disinfection, especially if you use accessories which are disposable. And of course, several guidelines have now suggested that there is no need to test for both HCV or hepatitis B before doing an endoscopy procedure, because we know that if you follow the standard guidelines, nothing happens. Now, what are the standard guidelines? Again, I don't want to go into the details of this. We do a high-level disinfection, and now it's using either glutaraldehyde, which is going out more parasitic acid. But if you want to sterilize your accessories, what is recommended is ETO. Again, some controversies about ETO use, but that's what we use in our institute, and that's what is recommended. But what is happening also is that all the accessories are now becoming disposable, and therefore this question of sterilization also goes down. So high-level disinfection, disposable accessories will prevent us completely from, of course, developing transmission of hepatitis C, and of course B. We know that B, all of us are going to get immunized against this. The third important point was what are the potential of this infection being transmitted to the endoscopist or healthcare worker in the endoscopy unit. We are now suggesting routine use of not as very high-grade PPI, but standard PPIs, including masks, eyewear, surgical gown, gloves, and of course shoe covers. So this is becoming standard in all our therapeutic endoscopy procedure, so that the transmission goes down. Of course, if you want to totally prevent this transmission, and the future is going to be disposable endoscopes, they're soon coming in. We already have the disposable duodenoscopes with us in our institute, and I think next 5 years, all endoscopy is going to become disposable, and therefore this problem won't exist. And finally, the take-home messages would be that proper endoscopic disinfection would not transmit this infection, so it's not a problem in us. I would of course still like to know the HCV RNA levels in these patients. In a patient like this, we would use completely disposable accessories so that transmission possibility goes down, and of course we'll be prepared in terms of a PPE for the endoscopies. Thank you.
Thank you very much, Reddy, for the practical suggestions. And there are several questions are there, but fortunately they are all been dealt with, because they are all practical, and then our people have dealt with these questions already. There's only one question which I would like to ask Dr. Akash. Akash, are you there? This is a HCV patient in pregnancy. What will you do? She was incidentally found to be HCV positive.
Sir, so far none of the, so that I'll break this question into two parts. One is if the patient is incidentally detected to be Hep C positive during pregnancy for the first time, and if there is no cirrhosis, no decompensation, then these are the patients where we would not be doing anything at all. There is very low risk of transmission from the mother to child, and there is very low risk of the infection to the complications to the mother herself. The second scenario will be where the mother is a cirrhotic and found to be during pregnancy found to be cirrhotic and having Hep C. So there the management will be what we would manage for the cirrhosis patients. There will be no specific treatment which will be required for Hep C as such. Again, it will be cutting short the second stage of labor. That is the main thing. None of the drugs for Hep C are approved during pregnancy. However, if there is, since there are few studies which have emerged now on the safety of these DAAs during pregnancy, therefore, in an extraordinary case, you may think of offering therapy if it is life-saving to the pregnant mother because of her advanced liver disease.
Thank you very much. Dr. Koshi, would you like to wind up this session? Thank you very much for chairing and also winding up comments.
I think the discussions were excellent, and I don't need to waste more time. I think everyone very appropriate and very crisp and nice discussions. Thank you to everybody. Thank you.
Thank you very much, all the viewers. And then we have come to the end of the session. I know we have exceeded our time. That's because of this technology COVID has brought us that we are all doing it, and then this series will be available in the YouTube for anybody to see. So it doesn't matter even if you have crossed about your limits, but you can always, we'll always be gained by seeing it and again whenever we are. With this, I thank all the chairpersons and all the panelists, who have excellently discussed the very practical questions which we had posed them. And I thank you very much. I thank Dr. Reddy for the session and also for his comments and for the opportunity which has been given for this platform. Thank you very much.
Thank
Over to
you.
Dr. Reddy. Would you like to say something? Yeah. Right. Okay. Thank you.
Thank you all. Bye.
Thank you. Thank you very much. Thank you all the people who have been there in the previous sessions. Thank you.